Well, first of all, you look all tired and sleepy and getting ready for lunch. By the way, I just wake up this morning, no voice. So thank you, Mr. Chairman. Thank you, Abir. Thank you, Dr. Ahmed. Thank you, KGA, for having me here in my second country. Everybody knows that I love Kuwait. I love Kuwaiti. Can I be a member of KGA? How much is the fee? Okay. So I thought the professor was going to start first. Thank you, Heba, for this gift. By the way, I just done the talk last night because I wasn't sure I'm going to debate for or no for anticoagulation. So I done this slide. So nothing to report in this talk. So I don't think we have a voting, but I want to raise a hand. What is your specialty? GI, hepatology, hematology, liver transplant. So I want to see the hematologist. Obviously not. Prof, are you a hematologist in your practice? Where is the professor? Don't know. So how many patients did you start anticoagulation over 2022 for portal vein thrombosis? Your choice is 5, 10, 1, 0. So who voted for 0? God, there's too many people starting anticoagulation. Scaring me. So what is my task? Do we really need to anticoagulate in our clinical practice facing portal vein thrombosis? Are we ready to deal with possible catastrophic bleeding related to anticoagulation for portal vein thrombosis at the middle of the night and leave beds and cause and curse anticoagulation with minimal benefit? I vote for no, I don't want to. Hepatologist, but we still do endoscopy, by the way. So let's go over a few things in portal vein thrombosis, and then we'll see either convince you or the Prof. Mike will convince you the other way around. So portal vein thrombosis frequently occur with cirrhosis of the liver, and we see it in non-cirrhotic, mainly related to inherited or acquired prothrombotic states, but obviously not in our practice, usually in hematologists. And when we see them, we always refer them to hematologists to investigate them if the patient is non-cirrhotic. So this is the common causes of portal vein thrombosis. More than 1/3 of patients that we're seeing related to cirrhosis. Again, around 30 to 40% related to malignancy, related to intra-abdominal malignancy like hepatocellular carcinoma, pancreatic CA, or infections and inflammatory conditions like appendicitis, cholecystitis, diverticulitis. But systemic causes in patients for hematology, we see inherited thrombophilia, again in 20% of the practice, or acquired thrombophilia like myeloproliferative disorder and JAK2 mutations. So the majority of patients in our practice is related to cirrhosis. So the epidemiology, the prevalence of BVT in cirrhosis have been reported to around 0.6 to 16%. And those patients usually, again, in patients with hepatocellular carcinoma, 35% of cirrhotic may have hepatocellular carcinoma. We see a tumor thrombus or portal vein thrombosis secondary to HCC. So the majority of patients with portal vein thrombosis we see in asymptomatic. And this is very important. I want you to see the majority of our patients are asymptomatic. While non-cirrhotic, non-malignant acute portal vein thrombosis present with something of abdominal pain, 90%, fever and ascites. And to tell you the truth, in my own clinical practice, those are very few that I'm seeing. Some of those cases are serious and can extend to superior mesenteric vein and lead to infarction and bowel ischemia. So those patients you should keep an eye on. So you know all the evaluation of patient with portal vein thrombosis, liver function, we diagnose in ultrasound, sometimes CT, MRI. Those patients would deserve endoscopy to look for portal hypertension and esophageal varices, and definitely some of them they need thrombophilia workup. And majority of our practice in gastroenterology and hepatology, we refer them to hematologists. So this is the classical slide of the treatment, anticoagulation, thrombolysis, thrombectomy, and tips in certain cases. What is the goal of the treatment? When we think about anticoagulation, we want resolution of symptom, prevention and treatment of ischemia, which is rare but can happen, prevention of thrombus extension, and prevention of complication. Again, I want to focus on the red, anticoagulation, there is too many benefits. However, in non-transplant candidate and patient with advanced liver disease, there is little data show benefit of survival if you anticoagulate those kind of patients. Remind you, we are hepatologists and gastroenterologists and not hematologists. So in non-cirrhotic, non-malignant acute portal vein thrombosis, I picked those two guidelines. So the ACCP recommend anticoagulation. So I made your life, Prof, easy. So there's grade 1B evidence of anticoagulation for symptomatic portal vein thrombosis. So I give you that. Do not suggest anticoagulation for patients asymptomatic, incidentally diagnosed, and those are majority of our practice as a gastroenterologist and hepatologist. The ASLD guidelines again suggest anticoagulation for all acute. So that's a point for you, Prof. Michael. In non-cirrhotic, non-malignant intra-abdominal inflammation and infection, literature is very sparse. However, there is no randomized controlled trial to suggest anticoagulation. Again, acute portal vein thrombosis in setting of liver cirrhosis. In liver cirrhosis, those patients, they have procoagulant protein and anticoagulant. So maybe there is creating a hemostatic balance in those patients. Again, in those patients, we are not sure we anticoagulate or not, because majority is asymptomatic. But there is no randomized controlled trial showed evidence in treatment, except there's a few case series here and there. And above half of those patients in a setting can be asymptomatic and incidentally diagnosed. Acute portal veins in setting of liver cirrhosis shown that BVT can lead to worsening liver function and increased mortality. And those in this setting, there is maybe some effect on morbidity or mortality at time of liver transplant. So this is another thing that we need to think in patients with liver transplantation. If you develop acute portal vein thrombosis, there is maybe some benefits waiting for transplant. So when to consider or not to consider portal vein thrombosis in patients with cirrhosis, many factors should be taken consideration. Acuity, transplant candidacy, comorbidity, bleeding risk, and presence of or absence of inherited coagulopathy. Those are summary of case series in liver cirrhosis without anticoagulation. Again, I highlighted majority of the data, whereas the highest number of patients in those case series showed no benefit of anticoagulation, recanalization up to 50%, and there is some data show there is some evidence. However, it's 50-50. More than a handful of studies, some of them show benefits, some of them did not show benefits. This is a nice diagram I found last night. If you have a patient with portal vein thrombosis, you need to think, are they symptomatic or non-symptomatic? If they're symptomatic portal hypertension, you need to control them by endoscopic therapy, large volume paracentesis. And again, once you control symptomatic portal hypertension, you may want to think about anticoagulation. But the majority, as we said, are non-symptomatic. And if the thrombus is less than 50% with no SMV extension, do not anticoagulate. Wait and see if they improve, and this is the majority of patients, you will follow them up. If they progress, you want to think about anticoagulation. Again, if the patient is liver transplant candidate, do an ultrasound, CT scan, MRI, do endoscopy, do a careful assessment of the patients, treat their portal hypertension accordingly if it's primary or secondary prophylaxis for esophageal varices, and again, look at the platelet. Carefully consider the risk of bleeding in every patient. If the platelet is less than 50, then you need to think about no anticoagulation because of the risk. But if the platelet is more than 50,000 and the patient liver transplant candidate, that's the cases that you want to think about transplant. This is a summary of guidelines for acute portal vein thrombosis. If non-cirrhotic, non-malignant, there is evidence for anticoagulation, as we said earlier. However, conservative management in certain cases where patients have very high bleeding risk, you want to think again it's not for anticoagulation. Portal vein in thrombosis, this is a summary. Again, majority of those patients are asymptomatic, and there is no clinical trial suggested benefit of anticoagulation. Just a second, in portal vein thrombosis in malignancy, anticoagulation is appropriate for majority of those patients. However, certain selected patients, if they are asymptomatic and diagnosed in the middle of the pregnancy, you may want to consider conservative therapy. This is just a summary of different guidelines, just repeating itself again: asymptomatic, cirrhotic, I think we should be very careful with anticoagulation. However, patients with acute symptoms and transplant, again, those patients, again, I give it back to Prof. Michael to consider them for anticoagulation. Different guidelines, American, European, and Canadian, again, stress the same point for what I mentioned earlier. So I think I've done my time. In summary, majority of portal vein thrombosis seen in our gastroenterology and hepatology practice, they don't deserve anticoagulation because of the risk is far more than the benefits with no clinical trials of just changing in morbidity or mortality, and it could be harmful to wake you up. Thank you so much.
Thank you, Dr. Mohamed.